So good morning, everybody. First, I want to start by saying that I'm honored to be invited to speak here today. And I'm especially honored to follow behind Dr. Marin, who trained me during my fellowship and who taught me most of what I know about endometriosis, actually. I want to start by saying that today I'm going to be speaking about sort of a difficult topic. For a 15-minute conversation about this, it has very limited evidence behind it, which makes it easy and hard to talk about. So today I'll talk about endometriosis and associated disorders with endometriosis that results in sexual dysfunction, painful intercourse, and painful orgasm. So I have no financial disclosures. So before we begin our conversation about this, it's, as we all should know in the room, but the definitions behind dyspareunia is pain during and after intercourse. And there's superficial dyspareunia and deep dyspareunia. Superficial is more pain in and around the introitus, while deep remains deeper with penetration. So it's always important for me when I talk to my patients about their pain with intercourse, basically to specify as to which type of dyspareunia they're mainly speaking about. So pain with intercourse and painful orgasm and sexual dysfunction is a major issue for a lot of our patients. As physicians, we tend to focus on what we think we can cure and focus on first and foremost. So for a lot of us, our primary focus remains the chronic pelvic pain they're experiencing, or for some of us, the infertility that they're experiencing. While intercourse becomes an issue that we don't focus as much on in our evaluation and in our discussions with them. It has a major impact on their sex life, on their relationships, and on their psychosocial well-being as well. So we know from the studies that have been done that pain with intercourse and painful orgasm results in decreased number of intercourses, avoidance of intercourse, feelings of guilt for the partner, and feelings of blame by the partner, feelings of resentment, avoidance of relationships, decreased number of orgasms, depression, anxiety, and stress overall. For endometriosis and dyspareunia, we have research that shows us that the most common complaints that people report when they come to see you regarding their medical care about endometriosis is their chronic pelvic pain, their dysmenorrhea, and their dyspareunia. Dyspareunia is 5 times more common in patients with peritoneal endometriosis than controls. So the question remains, for patients with endometriosis, how does endometriosis cause dyspareunia for them? So the studies that have been done sort of focus on a few things. Implants themselves being painful. We know that uterosacral nodularity on examination, when we discuss this, that's where the patients feel pain, often when you do your examination. The implants themselves have nociceptive receptors in them and have increased number of nerves in them. So that could account for the pain that they feel during intercourse. In addition, prostaglandins that are associated with endometriosis. We know endometriosis is a disease of estrogen as well as prostaglandins. The overall writing theme with endometriosis also remains the question of central sensitization. Does pain overall be perceived worse than it is because of a centrally acting reason? Peripheral sensitization. And the other thing which I'm going to focus on a little bit more of is the concurrent diagnoses of other diseases which can cause dyspareunia. With endometriosis, what do we do that can cause problems with sexual function, dyspareunia, and painful orgasm? In our efforts to eradicate an issue, we ourselves can cause another problem. So what do we do for a lot of our treatments? We know that we give birth control pills, right? Often for our treatment of endometriosis. We know the effects of birth control pills. It decreases estrogen, it decreases testosterone, which could decrease libido, could decrease vaginal lubrication, and in and of itself cause issues with sexual function. GnRH agonists. We know we essentially are putting our patients into a menopausal state. So we've decreased their estrogen basically to nil, as well as decreasing their testosterone as well, resulting in a similar thing. With SSRIs, which often we'll give for patients with their concomitant depression or overall well-being for them, those of themselves, we have multiple studies showing that it affects their ability for libido, for arousal, and actually to attain an orgasm. So endometriosis is one culprit, but physicians are another culprit for this. So I like this slide, and I also don't like this slide because it did bring light to one issue that we often see and deal with these patients, which is the Vulvodynia category. However, it sort of put it into light that the vagina was depressed, which is really not right. But it brought it to the surface. Other disorders that we see often associated with endometriosis that can also result in dyspareunia. So for many of our patients, they have concomitant pelvic floor, either defined as tenderness, hypertonicity, or spasm. And in a chronic state of pain that they're in with endometriosis, it sort of goes hand in hand with that. So for patients with this, they'll often complain of deep dyspareunia and or superficial dyspareunia, which we'll go into a little bit more about why that happens. But for the deep dyspareunia, the muscles themselves are very painful for these patients. Other issues that go hand in hand with it are painful bladder syndrome, or IC, the old category for it, where patients actually have pain at the bladder or under the bladder. So during intercourse, they'll feel pain at that location. And vestibulodynia, vulvodynia. So either in some theories, iatrogenically caused vestibulodynia, if you believe that birth control pills can affect the vestibule and the effects of the receptors and lack of testosterone, or neuropathic, or more centrally acting as well, whether there's a higher centralization to pain for patients who have endometriosis. So we know that endometriosis is linked to multiple diseases. We can see the linkage between the studies that define it linked to interstitial cystitis, Crohn's disease, irritable bowel syndrome, as well as multiple pain disorders such as fibromyalgia, chronic fatigue syndrome, and vestibulodynia, vulvodynia. The next topic I'm going to briefly talk about is painful orgasm, which is an interesting topic. I actually, over the past year, have seen quite a few patients who've come to me with complaints of having incredible amounts of pain after orgasm, to the point that they've avoided sexual intimacy for fear of having an orgasm. And when I did my lit research on this, when I first started seeing these patients, because it's not something that's often discussed in residency or fellowship, I was really unable to find a lot of literature behind this or explaining this. So I actually put this question, or posted this question, to another society that I'm a member of, the International Pelvic Pain Society Forum, and really didn't get a whole lot of responses back, which shows to me that this is really a topic that is just not really well researched as to why patients have these painful orgasms. For the responses that I got back were somewhat interesting. I actually spoke to a pelvic floor physical therapist who I work very often with and asked for her feedback and her 2 cents regarding this. And her focus really was that physical therapy can be very beneficial to these patients. So we may not have a great answer as to why it occurs, but that she's seen a lot of success with this. I'd actually, in part of her etiologies that she brought up was positioning, which is interesting, that patients, when they achieve orgasm, are positioning, or basically malpositioning their bodies, which can lead to them having pain. They tend to tense their pelvic floor muscles as well. Questions otherwise would be, does vasodilation cause it? Is there an underlying pelvic floor tenderness to it? Nerves issues, pudendal ilioinguinal nerves, the local nerve irritation during orgasm, central sensitization. We know there's a release of oxytocin during orgasm. Could that play a role in this, especially for patients with endometriosis, and prostaglandins as well? One of the answers that I actually received was from Dr. Stege, who reported that one option for treatment for these patients is to give them nifedipine, which was somewhat interesting as a calcium channel blocker and etiology, but he had a lot of success with giving this treatment for patients with painful orgasms. So that brings me to some treatment options, and this is more cursory because there's a lot of option treatments for. So patients with endometriosis, we know that actually has been well studied, that excision of the endometriotic implants, nodules, does result in decreased dyspareunia for these patients. For patients with interstitial cystitis, bladder pain syndrome, painful bladder syndrome, options for treatments for them, we know of Elmeron, we know of bladder installations, and physical therapy as well. For vestibulodynia, this is sort of a difficult topic because there's lots of options out there for treatment and not a lot of data behind what's the most effective treatment for it. But for those patients, depending on the etiology of the vestibulodynia, topical estrogen, testosterone, other compounded medications with inclusions of like gabapentin or your TCAs or lidocaine, vaginal dilator therapy for these patients, capsaicin, or vestibulectomy. For pelvic floor tenderness, we know that pelvic floor physical therapy works really well. There's also data coming out on Botox therapy for these patients as well. And for painful orgasm, pelvic physical therapy, NSAIDs prior to intercourse, and questionably nifedipine for. A final word about this topic in general, which was a great quote from Fritzer, is that even with treatments, a principal pathogenic mechanism in dyspareunia is altered awareness of pain recurrence due to previous experience of coital pain. Therefore, the focus during sexual intercourse turns to sensation of possible pain instead of enjoyment. So basically, even if we treat these patients well, we do good surgery for them for their endometriosis, that they still have this learned behavior of associating pain with intercourse. So perhaps a more multifactorial treatment for these patients with inclusions of surgery as well as possible physical therapy, vaginal dilator therapy, and or a sexual therapy, sex therapist. And thank you.